Today I'll talk about trigger finger. So trigger finger is a condition that caused by inhibition of smooth tendon gliding that due to mechanical impingement that affect the A1 pulley that cause progressive pain, clicking, catching and locking of the digits. So anatomy, it affects the flexor digitorum profundus and also the A1 pulley. Flexor digitorum superficialis is usually not affected. For the incidence, it affects 3 to 5% of general population, but those with associated condition will have a higher risk. For example, those with previous history of calcific tendinitis or tenosynovitis or medical conditions such as DM, sarcoidosis, gout, pseudogout, or hypothyroidism. The symptoms of classification divided into 4, 1, 2, 3, and 4. 1 is when there's a pain over the palmar area or over the A1 pulley area. And then class 2 is when there is a clicking over the finger. And then class 3 is when there is locking but passively able to reduce back. And then class 4 is locking, which is cannot be passively straighten back the finger. For symptom, usually it's a progressive pain over the A1 pulley area, and then patient will complain of a clicking, catching, and sometimes locking of the finger. They might have some radiation pain radiating to the palmar or over the distal of the finger. Physical examination, there will be palpation. On palpation, there will be tenderness over the A1 pulley area, and then possible able to feel nodule over the A1 pulley area. And then flexion and extension depends on the stage of the trigger finger. Sometimes during flexion it's not able to straighten back, like if it's of class 4. Then repetition of flexion and extension can reproduce the symptoms. And then radiology wise, usually not much of importance and not helpful in the diagnosis. And then for the treatment divided into operative and non-operative. Non-operative usually can prescribe patient with NSAIDs to reduce the inflammation and pain, and then can put on spleen. Spleen usually can fix the metacarpal phalangeal joint and the distal interphalangeal joint. Usually the proximal interphalangeal joint is spared from the spleen. And then activity modification, and also can offer patient corticosteroid injection. Usually offer 1 to 3 times injection over in or superficial to the A1 pulley area. However, need to inform patient about the complication of risk of a tendon rupture and fat atrophy. If non-operative methods is not helpful, then patient might need to undergo surgical intervention, especially those with a locked finger which is not able to straighten. Surgical intervention, they are able to do superficial release of the A1 pulley or open method and debride the A1 pulley area. And then for surgical intervention, usually need to inform patient about other possible complication like radial digital nerve injury or bowing of the finger post-op due to injury of the A2 and A4 pulley. That's all. Thank you.